Hello, my name is Alicia Aguilar, and my partner, Christine Glave-Smith, and I, from the United States University with Professor Rebecca Richmond for our F&P 594 course, did our Week 6 topic PowerPoint slide on seborrheic dermatitis. The contents that I will be speaking about is the introduction, epidemiology, etiology and risk factors, anatomy of the skin, pathophysiology, clinical features, diagnostic approach, treatment, and attached to our PowerPoint will be our slides for your review. Seborrheic dermatitis is a papulosquamous disorder patterned on the sebum-rich areas of the scalp, face, and trunk. When localized to the scalp, it is commonly referred to as dandruff. In addition to sebum, this dermatitis is linked to malassezia, immunologic abnormalities, and activation of complement. It is commonly aggravated by changes in humidity, changes in seasons, and trauma, such as scratching, for example, or emotional stress. The severity varies from mild dandruff to exfoliative erythroderma. Affected individuals are usually healthy, although seborrheic dermatitis has been associated with HIV infection, Parkinson's disease, and a number of other neurologic disorders and use of neuroleptic medications. The prevalence rate of seborrheic dermatitis is 3 to 5%, with a worldwide distribution. In the United States alone, $300 million is spent annually on dandruff over-the-counter treatments. Dandruff, the mildest form of this dermatitis, is probably far more common and is present in an estimated 15 to 20% of the population. Seborrheic dermatitis has a biphasic incidence occurring in infants between the ages of 2 weeks and 12 months and later during adolescence and adulthood. The peak prevalence of clinically significant seborrheic dermatitis is in the third and fourth decades. The actual prevalence is probably much higher when mild cases are included. Men are affected more frequently than women. The prevalence of seborrheic dermatitis is increased among individuals with HIV infection, in whom it may be a presenting sign. The prevalence has been estimated to be around 35% among patients with early HIV infection and up to 85% among patients with AIDS. Patients with Parkinsonism frequently present with seborrhea, oily skin, and seborrheic dermatitis, both of which may improve with L-DOPA therapy. The exact pathophysiology remains unclear. Malassezia organisms are probably not the cause of the disease, but are a cofactor linked to a T cell depression, increased sebum levels, and an activation of the alternative complement pathway. Persons prone to this dermatitis also may have a skin barrier dysfunction. Individual susceptibility factors include immunity, epidural barrier genetics, neurogenic factors, emotional stress, and nutrition, for example. Various medications may flare or induce seborrheic dermatitis. These medications include auranofin, orthoglucose, buspirone, chlorpromazine, cimetidine, ethionamide, fluorouracil, gold, grisovolin, haloperidol, interferon alpha, lithium, methocillin, methyl-dopa, phenothiazines, psoralins, stanozolol, dioxin, and trioxylin. Other likely risk factors for the disease include Parkinson's disease, oily skin, also known as seborrhea, immunodeficiencies such as HIV infection, positive family history of psoriasis or seborrheic dermatitis, androgenic alopecia, and, of course, emotional stress. The skin is the largest organ of the body with a total area of about 20 square feet. The skin protects us from the microbes and the elements, helps us regulate body temperature, and permits the sensation of touch, heat, and cold. Skin has 3 layers. The epidermis, the outermost layer of the skin, provides a waterproof barrier and creates our skin tone, composed of 5 layers, including the stratum basal, the stratum lucidum, stratum glandulosum, stratum spinosum, stratum corneum. The dermis beneath the epidermis contains tough connective tissue, hair follicles, and sweat glands. The deeper subcutaneous tissue, hypodermis, is made of fat and connective tissue. The skin's color is created by special cells called melanocytes, which produce the pigment melanin. Melanocytes are located in the epidermis. The cause of seborrheic dermatitis is not known. Seborrheic dermatitis is not a disease of the sebaceous glands, nor is the rate of sebum excretion increased in patients with seborrheic dermatitis. Nonetheless, sebaceous glands appear to be necessary for the development of seborrheic dermatitis, as indicated by the predilection for body sites with increased numbers of sebaceous glands and larger sebaceous glands, the face, scalp, upper trunk, external auditory meatus, and the anogenital area. In addition, the infantile form is common early in the first year of life, when androgen-producing enlarged neonatal adrenal glands and transplacental transfer of maternal androgens stimulate the growth of infants' sebaceous glands. Sebaceous glands may play a permissive role in the pathogenesis of seborrheic dermatitis, possibly by creating a favorable milieu for the growth of fungi or genus Malassezia. The lipid-dependent Malassezia, formerly known as Pediosporium ovale, is saprophyte of normal skin that thrives at the sites of predilection for seborrheic dermatitis. In the presence of individual susceptibility and immunologic factors, Malassezia colonizes the skin, grows, and secretes lipases. The secreted lipase hydrolyzes sebum triglycerides into the saturated fatty acids, which penetrate the skin and cause epidermal hyperproliferation, leading to parakeratosis, and inflammation leading to spongiosis. This is followed by shedding of the flakes, loss of skin barrier function, inflammation, pruritus, skin hyperproliferation, and the eventual establishment of seborrheic dermatitis. Seborrheic dermatitis may first appear soon after puberty or later in life. It is usually characterized by well-demarcated erythematous plaques with greasy-looking yellowish scales distributed on areas rich in sebaceous glands, such as the scalp, the external ear, the center of the face, the upper part of the trunk, and the intergenous areas. The scalp, which is the mildest and most common form of scalp seborrheic dermatitis, is dandruff, also known as pityriasis sicca, in which the scalp shows fine white diffuse scaliness without underlying erythema. Dandruff may be asymptomatic or accompanied by mild pruritus. More severe forms of scalp seborrheic dermatitis present with visible inflammation consisting of patchy orange-red to salmon-colored or grayish-white plaques covered with yellowish greasy scales, mostly over the temporoparietal areas, or with concretions of scale around hair shafts. Lesions may extend to the post-auricular areas, where they often develop fissures, oozing, and crusting, and to the outer canal and concha of the ear, sometimes with marked pruritus and superinfection, also known as otitis externa. The face, which is the facial lesions, favor the forehead below the hairline, the eyebrows, and glabella, and the nasolabial folds. They may extend to the cheeks and malar areas in a butterfly distribution. The mustache and beard area are frequently involved in men with facial hair. Shaving helps with treatment and control of the disease. The periocular. Blepharitis with redness of the free margin of the eyelids and yellow crusting between the eyelashes may be the sole manifestation of seborrheic dermatitis or may accompany its more classic distribution. The trunk area of a human body. 5 patterns of truncal involvement have been described: moist, erythematous, intertrigo of the axilla, inflammatory folds, umbilicus, and genitourocular area. The patelloid pattern, consisting of polycyclic, finely scaly, thin plaques over the sternum or intrascapular area. The annular or arcuate, round to oval, slightly scaly plaques on the trunk, sometimes with hypopigmented central clearing, known as seborrheic dermatitis. The pitreosiform pattern, mimicking Pitreus rosea, comprised of 5 to 15 millimeters oval-shaped scaly lesions distributed along the skin tension lines. The psoriasiform pattern, with larger red rounded plaques covered with thicker scales. In patients with HIV, the seborrheic dermatitis tends to be more extensive and severe in HIV/AIDS patients. It sometimes involves unusual sites, such as the extremities, and may be difficult to control. Seborrheic dermatitis is frequently observed in patients with CD4 counts less than 400 cells per microliter, and is more diffuse and severe in patients with CD4 counts less than 200 cells per microliter. It may regress with ART, antiretroviral therapy. However, seborrheic dermatitis also may be a cutaneous manifestation of the immune reconstruction inflammatory syndrome in patients on antiretroviral therapy. The diagnostic approach, primarily a clinical diagnosis made with proper, is done by history taking, waxing, knowing their waxing and waning severity, a physical examination, the distribution of involvement. A skin biopsy may be needed to exfoliate erythroderma. Fungal culture can be used to rule out tinea capitatis. Tinea capitatis is rare in adults, mostly found in children or younger adolescent people. And also Parkinson's disease and HIV diagnostic tests if there's unusual distribution. Also, histopathologic findings, non-specific, but may be present in a chronic or acute stage. The acute stage, which is the inflammation noted to be perivascular and perifollicular. Also, spongiosis and psoriasis form hyperplasia. Parkeratosis around the follicular opening and shoulder parakeratosis. The chronic stage may appear similar to psoriasis, distinguished by thinned ridges, regular acanthosis, excitosis, parakeratosis, and absent spongiosis. These are the differential diagnoses on this chart, which we see the areas such as the face, trunk, and other areas, and the differentiation. So the rosacea, for example, response to rosacea treatment versus the impetigo, smear of bacteria. And the trunk, which is the pityriasis rosea, and the other one is pityriasis varus color. And of course, we have the mild psoriasis vulgaris, which is of course indistinguishable, and the dermatophytosis. Treatments such as lifestyle modification through sunlight exposure to relieve symptoms, avoidance of precipitating factors. But of course, anytime under sunlight, make sure to always apply a good amount of SPF sunblock. And of course, pharmacotherapy. The goal, of course, is to prevent complications and reduce morbidity. Shampoos or creams containing zinc, pyrrolidone, selenium sulfide, tar, salicylic acid or sulfur, topical antifungals, ketoconazole, first line and available in various formulations. Topical corticosteroids such as the betamethasone for severe acute flares, and of course we can have systemic fluconazole or ketoconazole for refractory or severe cases, and immunosuppressant therapy, tacrolimus ointment, and pimecrolimus. Thank you so much, Professor and fellow classmates, for listening and reading our PowerPoint presentation delivered by Alicia and Christine Glave-Smith. Thank you and have a nice day. Bye-bye.